Reassurance is part of most clinical practice guidelines across healthcare, and yet there is very little guidance and research out there as to how to go about and do it successfully. However, we have some very new recent research in back pain that's given us some better ideas. So today I'm speaking with the lead author, with Ian Cowell, who's a clinician, researcher and educator with the Evolve Pain Academy. And so on this episode of Clinical Communication, we're discussing what did and what did not result in effective reassurance and how we can apply that to real life practice. If you find this useful, please do go subscribe. Please do go share it with others. You can find Ian on LinkedIn and X or Twitter. I am at bybrow across all social medias, or you can email into clinicalcommunication@outlook.com. Thank you for watching or listening, and I'll speak to you next time. Interesting. And so the paper's been out now about, is it a month or
Yeah,
a few weeks?
yeah.
How's feedback been?
Yeah, so that emanated from my Viva. So this was data that was in my PhD,
Yeah.
but really didn't write up until after the PhD. So it's one of two papers that I wrote after the PhD from that data. And it emerged from a conversation that I had during my Viva from one of my examiners who said, look, this is interesting stuff around concerns, but I'm really interested in for you to consider as a postdoc consideration, not in terms of the Viva here and now, but what happens to these concerns? How are they managed? He talked about how are they treated, which is a bit ambiguous for us as therapists, but he was basically saying, look, what happened to them? I'd love to see the trajectory beyond eliciting concerns. And that was something I went back to the data then to consider. Go, yeah, let's look at that. Let's look at it further down the chain. And so the feedback around it, for various reasons, has been quite strong because it's interesting. People have been doing some work around reassurance. There previously hasn't been very much.
No.
So people have reached out a bit to say, look, I'd like to know a little bit more about the work. Um, it resonates with my own clinical practice. This issue around telling and delivering information without checking out with the patient the value and how much that will resonate with the patient, and does it even target the concerns, was something that seems to have resonated with people's experience of practice and education. So, it's early days, but certainly it seems to have gained some traction.
And I will be clear with this. There'll be a link to this because it's open access, isn't it?
It
So
is.
there'll
It
be a
is.
link to this in the description for people watching or listening. I mean, we're going to go through a few things today that some of which you and I take for granted, but
Yeah.
maybe new for a lot of people,
Mm.
especially as right you said there. Like, and I was reading the article and thinking the same thing. There's not a ton about actually how to reassure people, not even put physio and pain to one side, like
Yeah.
just in medicine in general,
Yeah.
like
No.
not a lot.
No.
Um, I can think back, and I think you quoted it in the paper. There was a systematic review over a decade ago about
Yeah.
the
Yeah.
affective and cognitive reassurance then, but
Yeah.
there hasn't been a whole much more
No,
since,
no,
is
it
there?
hasn't. It
Do you know
hasn't.
why
And
that is?
I don't really, and when you think about its dominance within recommended practice,
Mm,
it's
mm,
something that we're all fully aware that we should be doing,
yeah,
but actually we don't know what it looks like, and we don't know what's effective,
yeah,
and so I don't know why there's been a gap in terms of research around that area. And it was just prompted, it just prompted me to consider it. And then once I did consider it, it started to speak to some of the bigger issues around us as practitioners.
yeah,
It started to talk to this instinct around telling and giving information without necessarily creating this foundation for that information to be successful.
yeah,
And it started to speak to that bigger picture. And, and we can talk around things like making sense of pain and how we deliver information and how we deliver good news, because
mm,
this should be good news
yeah,
to patients, normalizing scan findings that they think are attributed to their pain and disability. Delivering good news and reassuring patients with giving them evidence-based information should be clearly good news that should land as good news. But here was some trouble in the interaction
yeah,
because the platform around the way that was delivered wasn't done well enough. There
mm,
were some assumptions around this will be information that's going to be useful to you, right? So let me tell
yeah,
you. And the outcomes from that are fairly benign, but there was clearly trouble within the interaction where the patients were prepared to quite explicitly resist the reassurance that was being given to them.
Yeah.
So it was interesting to see.
It was. I mean, if we start on what didn't work with the
Yeah,
reassurance, and that
yeah,
was one of the things that I obviously knew, but I think hopefully stood out to a lot of people is that, as you rightly said, people would they assumed what to reassure the patient with. That
yeah,
makes sense, and that seemed for some people not go well, even
yeah.
if the information was, as you say, good news.
Yeah, yeah. And I think that's exactly right. And I think that at the very basic level, these were therapists that hadn't either checked out the concerns. I mean, at the end of the day, it's very instinctive, very understandable. And we fully acknowledge that if we're going to reassure someone, we should know what they're concerned about
Yeah,
in the first place to reassure them.
yeah,
And it's very interesting that there was this blind spot around the therapist's failure to do that. And this issue around preoccupation with their own agenda,
mm,
this focus on their series of questions, this focus on giving the right information, kind of looked like there was this narrative I'm going to give, this rhetoric I'm going to give you. It's going to come
mm,
fairly formulaically, and it's not going to be adapted to the needs of the patient.
mm,
And that's what it looked like. And as you say, patients were quite prepared to resist it,
mm,
particularly in one of the extracts where the therapist goes on and on over multiple turns of talk, reassure, like, this is really good messaging, like
mm,
normalizing, reducing the significance. This is something you don't need to worry about. We know that patients worry about this. There's the generic. We know that patients worry about this, but the truth is, we don't know whether you as a patient are worried about it,
yeah,
but you're still going to get the reassurance narrative regardless of that. And so it just went on and on and on. And then I think it was at the point where the therapist said, "Look, we'll come back to this." And the patient went, look, I'm really not worried about this. Like,
yeah,
if this was in relation to a report that the patient had brought along, a radiology report, like, I brought this along because I thought you might want to see it, but I'm actually not worried about it.
mm,
So,
yeah,
so you invest all of this time and all of this energy interactionally
yeah,
without having checked out the patient's
yeah.
concerns in the first place.
So, as you say, it was almost felt like they'd learnt the script, right? And if I recite the script, then that will do that, the job essentially.
Yeah,
Were
yeah.
they asking concern? Because you said
Yeah.
obviously they weren't always specific to the, but concerns being asked.
Yeah, so within this data around the reassurance, there were concerns questions. So there was two
Mm.
things. One is the concerns weren't asked,
Ah,
yet the narrative of reassurance came. And then there were other times where there was this inattentional deafness, so to speak, where they'd ask about the concern, the patient would say, "Well, I'm not really worried about that," and they would still give the narrative. So it's like
mm,
you're going to get it
yeah.
regardless. And I think there's something instinctive within us. And I see that within my own practice. And
Mm,
I see a movement away from that as I've developed my own practice. There is an instinct to want to give good information and to give good news. And we just have to remind ourselves that for that to be considered good news or to reassure, and we have to do a bit of groundwork
yeah,
with some communication. And,
yeah.
if I flip that and make some comparisons around medics delivering bad news.
Mm,
If you look at the volume of work that's gone into medics trying to understand how best we construct bad news, particularly in oncology interaction, if that comes coldly, it doesn't go well.
no.
So warning shots, developing the perspectives,
Mm,
getting an understanding of what the patient understands before delivering the bad news sets a platform for that news to be received slightly better. It's a strategic strategy around understanding
yeah,
where the perspective of the patient is implicated within your delivery.
yeah.
And this is evidence within our reassurance of therapists not doing that when delivering good
Mm,
news. So they're not
yeah.
asking the patient, "What's your concerns? Like,
Mm.
what worries you?" And so it didn't go so well, certainly within those first two or three extracts.
Do you know why? Why they didn't ask?
I mean, if we go back to some of the concerns paper or the concerns paper that I was involved, one
Yeah,
of the
yeah.
first CA paper, we saw in answer to that question, I think it's a preoccupation with our own agenda. I think we come from, certainly I do at 36 years qualified, we come from a very biomedical structure. We come from a very paternalistic structure
Mm,
where we're focused on our own agenda and to the detriment of the patient voice. So when we look at client-centered communication, putting the patient at the heart of the interaction,
mm,
that wasn't my training, that wasn't my focus. And so we're very preoccupied with our own agenda. And what we saw with eliciting concerns and the patient's concerns, when the patient voiced concerns, the therapist would do a couple of things. We would see often emotional concerns that were disclosed by the patient. The therapist would move the topic away. They
mm,
wouldn't develop the concerns. They would almost block the subject. They would topic shift.
yeah.
And that was both verbal and non-verbal. So there was clearly, and what we found is at the time that they blocked the patient verbally, they would then look into the chart away from the patient. So the eye gaze would go, the body orientation would go, the dominance then became the chart, which prompted seemingly the next question, which
Mm,
set the agenda away from the patient's concerns.
yes.
So in answer to why these concerns weren't elicited as a platform for reassurance, I think some of it speaks to a preoccupation with our own agenda. I think
Mm,
that's the first thing. And we also know from the quality work I was involved with that therapists, particularly around the emotional space, around emotional concerns, is they're not very comfortable about it. This is
mm,
not something they feel necessarily, some say may not even fall into their scope of practice, but some of them go, look, I recognize the value of it. I recognize understanding patient concerns. I understand why that might be of value, but boy, that's difficult. I don't feel comfortable with opening that
mm,
Pandora's box of emotions. So there's probably different facets to why these concerns weren't explored. Some of it is communicative competency, some of it is preoccupation with your own agenda, and some of it is just being uncomfortable with
mm.
it, particularly around that emotional concern space.
Interesting. I can kind of thought by now, I mean, ICE questions are drilled into medical students. Like
Mm,
they come out
mm,
asking them when they don't need to ask them at times.
yeah, yeah,
Um,
yeah,
and I'd have thought, I'd have thought it'd be part of most people's templates by
yeah,
now of
yeah,
questions. But as you
yeah.
say, it's quite, they might not, even if it's on the template, they might not want to ask
Yeah.
if you're afraid of the answer.
Well, it's a good point you make. And there's a couple of points to be made around that is the fact that, yes, we've moved very firmly into recognition of a multidimensional approach to dealing with patients with persistent pain. So the questions are clearly often part of, an evidence-based template.
Mm,
But the way that those questions are asked, I mean, you talk about the ICE questions that are, they're coming out their ears, that there is a focus on that, but there might be some issues around avoidance. But the way those questions are asked is another feature to
mm,
that, because when they're templated, there's something about the formulaic, clunky way that they're asked, when they're asked, how proximate they are, and how relevant they are to that moment is something that needs work. And certainly when
mm,
I've looked at some of the educational experiences that we've had around patients, therapists working with patients in live mentoring sessions, yes, the questions are asked, but the placement, the way it's asked, the adaptive communication required to make it look seamless, to make it look like it flies under the radar
yeah,
without looking clunky, isn't quite there. So
no,
there's this preoccupation with making sure I've ticked the domains,
mm,
but the skill of communication in terms of delivering that has been lost in the process. So
yeah,
we're still learning that, I think, and that's around opportunities to train, and that's why we think skills training, mentoring within our profession has been woefully lacking. Like my therapists were all saying, like, where's the opportunity to train? I mean, you talk about medical curricula and some of the work they're doing at Imperial College around the medical communication is tremendous,
mm,
tremendous stuff. But where are we as a profession in terms of having training fit for purpose? We've got the guidelines,
mm,
we've got what we know we should be doing, we've got very little empirical foundation, and we've got very little training to upskill therapists in this space. And so we're left with, we'll work it out. And
Yeah.
so it needs more structure. And that's why there's been so much consideration around the Evolve project, around what training needs to look like to upskill therapists within this space. And, that's such an important part of the work. And we consider all of these things. We
Mm.
consider, do you have the knowledge around what needs to be asked and what needs to be looked at? We're talking about the communication aspect, that
Yeah.
the competence are broad beyond just communication. Um, what are the skills you need, and what training approach do we need to embed those skills? And how do you clinically reason and integrate communication and skills within live mentoring? So there's all those different phases that we think are important as part of that training journey. But I think we're coming from a long way back as a profession.
Yeah. Yeah. And I would make an assumption, as are many other AHPs as
Yeah,
well.
yeah,
Because because my understanding, the medics have had the comms training since I would say early 2000s. It's become more of a
mm,
regular permanent thing.
yeah,
I always say to people, when I went to uni 15 years ago, I was taught what to ask, but not how to ask it
yeah,
necessarily and when.
yeah,
My understanding is that some unis are doing some form of comms training now
yeah,
with the graduates coming through. So I know we've had some students recently who said they have these kind of communication workshops.
yeah,
They do various. So
yeah.
it's clearly, but it's not at the same extent of which the medical schools have. Granted,
No,
obviously, medical training is a lot longer and
yeah,
bigger.
yeah.
Um, I'm glad to see it obviously being talked about more at undergrad, but there's still postgrad, as you say yourselves, maybe a few others, but there's not a whole compared to, I don't know, the amount of shoulder courses I could go on or other things. There's not a whole host of stuff.
I mean, it's such an important point that you make, Ben, because you talk about the fact that you were educated about content but not process.
Mm,
So, these things require education, they require training. And when you look at the defense that everyone's had to make around the Restore, one of the big criticisms of Restore was the level of training,
mm,
and so up to 80 hours of training, and the training program is what's represented in the Evolve project. And when you look at that training, 80 hours, and if you compare that, well, if I go back to 1993 when I was learning manipulative physiotherapy or training through the MAC program, no one challenged the amount and the volume of training that I did, where the evidence base that underpinned that wasn't there.
mm,
And so, but no one challenged the volume of training that we did. But here and now, people will stand up and say, well, you know what? This is a hell of a lot of training. But when you think about it, how long does it train? How long does it take to train a psychologist? How long does it take to train a surgeon?
yeah,
You know, the whole culture of value that we put on communication has to change. It's there.
yeah,
It's paid lip service to. It's going like, this is an important part of your core competency. These are part of your standards. This is part of your guidelines. But then there's this gap. And then when there's energy put into creating a process of training that is fit for purpose, that demonstrates through the Restore trial, those type of impacts in terms of effectiveness and cost savings,
mm,
the challenge is, but the training took too long, which I find really frustrating, because these skills that we talk about need to be fine-tuned. They need to be developed.
yeah,
They need mentoring. You need skills workshops. So it makes sense to me that we have training that's fit for purpose. And as you say, in the medical world, there's been an acknowledgement of that.
yeah,
Within the psych world, there's been an
yeah,
acknowledgement of that. And we're just catching up, I think.
yeah.
And we've got a long way to go.
Of course. Oh, yeah, yeah. Yeah, it
Mm.
almost sounds like from what you were saying earlier. We don't just need people talk about breaking bad news, and we also need training in how to give good news in a
Yeah,
way.
yeah, yeah. Well, that's absolutely right. Absolutely right. And that speaks to not only reassurance, it also speaks to what's our end game with patients. We're
Mm,
trying to change behaviors that link towards pain and disability and reconceptualize their view of pain to enable them to do that.
mm,
And that requires that we understand their ideas, their concerns, emotions, and it requires that we become very skillful at changing behavior.
yeah,
Now, if we go too early on that, if we run the risks interactionally, of this backfire, of this resistance. We saw some of that within reassurance. So these things require skill, and they have to be learned.
You said about them almost following the script,
Mm.
about them missing the cues and kind
Yeah,
of sticking to an agenda.
yeah.
Is there anything else that made reassurance go wrong?
No, I think the key is around concerns and what we know about eliciting concerns. In terms of not doing it well, we've kind of covered. And, we shouldn't forget the non-verbal. We really
Mm,
shouldn't forget that. And there's been so little focus on the
no.
non-verbal. But the integration and symmetry between verbal and non-verbal communication is so integrated. When we saw these therapists shutting down terms of talk and shifting the topic,
Yeah.
the intonation of okay as they were looking at
Yeah.
the chart to look at the next question as they were reducing eye gaze and breaking that framework of engagement non-verbally was so integrated. So we shouldn't forget that. And I know that's repeating it, but it is an important point because what we saw on the other side of that, once we trained therapists, when we revisited from an observational point of view, how they dealt with concerns post training, well, we saw a completely different story. Now,
Mm,
remember, the reassurance happened at baseline before they were trained. So we don't know what reassurance looks like after training, but certainly we do know what eliciting concerns looks like after training.
mm,
And that looked radically different. That was a completely different story around communication process and how the therapist went around the business and the action of eliciting patients' concerns. And that was very different.
it sounds like from what you're saying that for reassurance to go well, then we then do the opposite of what made it go badly, essentially.
Yeah, yeah, and that's around being more patient-centered.
Yeah.
So it's around respecting the patient and their concerns and giving them a voice in the interaction. So as you say, if we're shutting people down and bringing back the interaction to our own topic,
Mm,
our own agenda, that that's detrimental to the patient's expression of their concerns.
yeah.
So of course the reverse of that then becomes true. Conversely, what we should be doing is asking about patients' concern, making that a topic of discussion.
Mm,
But once we get disclosure, rather than shifting the topic, can that be developed?
yeah.
Can that be developed with secondary questions, with prompts, with curiosity, with wanting to know more so
Mm,
that patients get a fuller expression or opportunity to voice those concerns?
yeah.
And that's exactly what we saw post training, which was really encouraging to see because from behind the camera and actually looking at the videos and for them as the therapists with the patients, it's all so much more comfortable. You would have observed effective and not so effective practice.
Mm,
And when you've got patients that are disclosing concerns and topics are being shifted away, it's a really uncomfortable moment in terms of the interaction. So this then conversely was much more comfortable viewing.
yeah.
These were patients, they were empathizing, they were validating their concerns, they were wanting to know more, they were interested in their feelings, they were interested in their thoughts. These questions came proximate to patient disclosure. They didn't look like they were clunky, they
Mm,
didn't look misplaced, they looked integrated and seamless. And that's how you want communication to look. It should naturally flow and be adapted to the moment. And that's what it kind
yeah.
of looks like, which was nice to see.
There was lots of reading through the ones that went well. Uh, it was basically respond to what their concerns actually were, as you say. Um, and I presume at times, if we're asking, and we should be asking what the concerns are, there may be times when we don't need to reassure someone at all
Yeah,
if
yeah.
they don't have any concerns.
Well, if they don't have any concerns, absolutely. I mean, unusual, but if they didn't have any
Mm,
concern, but certainly what you say around suspending reassurance at a
mm,
point when the patient voices a concern is an entirely reasonable thing to do, but to make sure you've signposted that that's something you'll come back to.
yeah.
Now, if you think about premature reassurance, which we've talked about, or reassurance that's given without understanding the concerns, it risks interactionally resistance. And
Mm,
certainly the patient doesn't affiliate or respond as if they're reassured.
mm,
you also might be in a position where you need to build your data. You
Yeah.
need to go, I can't reassure you. It's just not a reasonable thing. I can give you some platitude of hope and going, oh, well, don't worry, everything will be fine. But we
Yeah.
know that's not going to land.
No.
So, but to hear the concern, to understand the concern, acknowledge the concern, and say, look, there's things we need to look at. We'll come back to that. But that's
Mm,
something that's interesting to me and important clearly to you. But it's
mm.
something I'd like to come back to if we can. We've got other things that we'll look at. And then you've got to make sure that you come back to it,
Yeah, yeah, of
because
course.
that's a really important return that you've marked.
Yeah.
And I think that's a reasonable thing to do. Absolutely.
Yeah. I mean, my feeling, I think for my feeling of it's more sometimes with we ask about in beliefs and their thoughts and what's going on,
Mm.
but they also need to feel that you've got the data as well. So, I mean, there's plenty of times where we all almost want to pull the reassure trigger straight away, like someone saying, I don't know, I'm worried I'm going to be up in a wheelchair in 5 years' time. You want to go, no, you're not. You're going to be okay.
Yeah.
But they
Yeah.
need to feel that you've assessed them first and have the
Yeah.
data to then say
Yeah.
that.
Yeah, no, I completely agree. And what that speaks to is the credibility of the reassurance.
Mm,
And credibility of reassurance isn't there unless you've built up an evidence base around
mm.
how you deliver it. And I think that we'll talk about one of the key extracts either now or later
I'll do it. Yeah.
around the use of the behavioural experiment and
Okay.
how that reassurance came a lot later within the process of the initial examination. But your point around offering throwaway reassurance, albeit with good intention,
Mm,
giving good evidence, albeit with good intention, without having collected the platform of data to be able to be credible there is such an important point.
yeah.
It's such an important point. And the way we look at assessment and the way that it's just about building a therapeutic relationship as
Mm,
you build and collect data around reconceptualizing patients' pain in the service of behavioral change so they can pursue valid activities, pursue their goals in life. And that's person-centered care right there. So to glibly think you can deal with that within the first 5 minutes
mm.
is incredible, is
No,
incredible.
no.
You know, in the same way that phobias around spiders in a room without going into the room, don't worry about that. I'm sure you'll be fine when you get in there. It isn't going to land
No, no,
reassuring. So
no.
you have to. And I think that when you look at the medics around the way they use physical examination, so-called online commentary, the way they comment around the physical findings to offer reassurance is interesting because they use the physical examination findings. So this is now moving from the interview into the physical examination and building the data again,
Mm,
like I don't know, infection in the ear. Well, I'm looking into your ear. It looks all fine to me. Looks okay. So there's an online commentary, a way of commenting
mm,
on what you're finding that is delivered to be reassuring, but it's based on having a clinical context around when you do that.
mm.
So yeah, timing's everything, right?
Absolutely.
It really
That's
is.
a good point you were saying about the assessment, because patients will also know that, if you're doing a neurological examination, for example, the patient will see if hopefully, if one side is drastically weaker than the other, right?
Yeah,
Or if they're the same. They'll see if one leg reflexes and another doesn't. We have to rely on them to tell us if one leg feels or arm feels different to the other. So
yeah,
they'll be knowing, again, they're not trained to, but they'll be able to put the pieces together a bit to see
yeah,
if things
absolutely.
are not right or right, so to speak.
Yeah, absolutely. And that's absolutely right. And there might be some elements of expertise that we have that they may not relate to.
Yeah.
You're absolutely right. Patients have, capacity to understand what's going on,
Mm.
and we have to give them that appreciation that they can see what we're trying to do
Mm.
and can see the direction of flow of that. But I think that where we've got opportunity to reinforce that and to build insight and to build awareness on behalf of the patient and involve the patient, see, it's about collaborative communication. And I think that
Yeah.
this isn't something we do to patients. This is something we collaborate with them on. And I think if we remember that this is a journey of discovery and understanding that they have, and we have to collaborate, and it's important that we do that, then I think we just keep that in our mind.
Yeah.
And I think that's such an important part. And part of that examination is doing what you said, is collaborating with the patient and making known explicitly what you're finding,
Yeah.
and the significance of that,
Yeah.
because that's going to be important.
Absolutely. So you were saying about the behavioural experiments earlier, and in
Mm.
the paper it mentioned about one of the things that allowed reassurance to go well was the patient experiencing that.
Yeah.
Um, it's one thing to tell someone the reassurance with words and tones and all that stuff, but what was it about the behavioural experiments that you think, looking back, allowed them to be particularly reassuring?
So I suppose simply, I mean, when you look at behavioural experiments, what are they? They're patient nominated
Yeah.
tasks, activities, postures that they have nominated, that they've either got pain associated with, avoidant of, or distressed about. In this case, with this particular extract, this was a patient that had been for years since having an acute episode of back pain, wasn't prepared to bend, and was hugely avoidant out of fear of re-injury. So that was the context of that particular patient. So he'd nominated that as a particular activity that he was concerned about. So the thing about behavioral experiments is it is a form of exposure, but it
Mm.
also is beyond just exposure. It's trying to identify those behaviors that are unhelpful, that are maladaptive
Yeah.
around that exposure. And more than just telling the patient, it's trying to build the patient's awareness of those behaviors.
Mm.
So it kind of requires a certain communication where the patient is asked to play a role in understanding. Like, for example, on a sit to stand, someone who's propping and holding themselves tense and
Mm.
not prepared to bend their back. The questions around, what do you notice about the way you do that? What do you notice about your breath? And trying to understand the cognitions and the emotions that underpin the behaviors. Really, really important questionings around that context. So straight away, what you're doing is you're having conversations that are around their cognitions and emotions, but linked to their particular behaviors.
Mm.
And then you expose patients addressing those behaviors, facilitating change, offering them a new way of moving, and then seeing what happens in terms of their pain experience or distress. And the important thing, because this speaks to the importance of discrepancy,
Mm.
is kind of going, what was your experience of change? And this whole notion of violating expectations, like you said, when you bent forward, you thought your back would go. What was your experience? What actually happened? Did it match your expectation that you had prior to performing the task?
Yeah.
Because we know a lot of things like avoidance or fear of movement are driven by strong emotions around threat and worry about injury or pain. So the importance of then having conversations after the exposure to violate those expectations do a few things. They bring awareness to the patient. They have the potential to offer reassurance because here's someone doing something they didn't expect to do. And it's very hard to argue with your own data.
Yeah.
You may
Yeah.
want to
Yeah.
talk about the fact that bending will be okay. What
Mm.
we know about bending is it's good for you. It's important that you bend. It's good for your nutrition. It's important for your muscles. So you can have that conversation, and that can come quite early.
Yeah.
Here's a patient with high levels of threat around bending that you do an exposure training with.
Mm.
But more than that, you get them to understand and you help them understand by reflective questioning. You get them to consider their body in a different way. And that's a very potent context for communication around giving reassurance.
Yeah.
Something that you're worried about happening hasn't happened. It also gives you the option of reframing the pain. There's a patient who thought, well, you know what, I've got multiple levels of degeneration. It's important I don't. I've got a prolapse disc. It's important I don't bend. I've been told not to bend. Well, what's been your experience?
Mm.
What did you notice about what you did? What did you notice about the way it felt comfortable? What did you do that was
Mm.
different? So the reflective questioning, the questions that focus the patient around the body,
Yeah.
and the realization and the violation of what they expected to happen not happening seems to be the potent part of the behavioral experiment.
Yeah.
And it was interesting, that was arguably the strongest affiliation to reassurance in the
Mm.
extracts that we presented.
Yeah. And I think the key thing with that is also it's coming from them. Like,
Yeah,
as you said, they can't argue with their own data.
yeah,
Um, uh, and like we our beliefs are influenced by people and things that we trust, and the
yeah,
person we ultimately trust the most is ourselves.
yeah,
It's our own data, and it's hard, as you say, it's harder to challenge. I've interest, as you say, that was a very successful example, and
mm,
others as well. the response to that. So let's say, they got someone to bend who was feeling a bit
Yeah,
uncomfortable, or so
yeah, yeah,
do you, I'm being mindful not to go like, you don't want to go, ha, see, you're okay. Like,
yeah, yeah,
it's just a case of saying, what do you think? What do you notice?
yeah,
And just leave,
yeah,
because I think it'd be hard for some people just to leave it at that and not be like, well, see, it's okay to bend. Yeah.
yeah.
And to not
Okay.
almost rub it, I don't say rub it in their face isn't the right word, but
Yeah,
like
yeah, yeah, yeah.
drill it home, so to speak.
No, I get that. And I think that, respect for the patient and respect for the patient's journey,
Mm,
patients have often been incredibly invested in their beliefs for reasons that make sense to them. And
mm,
we have to respect that.
yeah,
We know their erroneous beliefs that are unhelpful for their behaviors. And we come into that moment in their life at that moment. And it's very easy to do, as you say, the eureka moment of exposure and that opening up the potential for the patient to do things they haven't done for years is a
yeah,
very strong, potent moment, but we have to handle that with respect. And it's really important that we do that because patients will say things like, I feel a bit stupid. I've done this myself. I've been doing this stuff all this time. I've avoided all this stuff, things linked to key things in their life that they've
yeah,
avoided.
yeah,
And, it's disingenuous to use that as an opportunity to say, look, come on, you can do this. But equally, repetition, building
mm,
confidence,
yeah,
building patient self-efficacy to perform the task is an important thing. And
yeah,
our confidence in the face of their fear is
mm,
really important.
yeah,
So our projection of your fear is your fear, but I'm not sharing that is an important communication thing in our face and in our language.
yeah,
And that's really important, particularly with patients with high levels of fear. And that isn't judgmental, but that's just going, look, I'm not buying that. That's not my position.
mm,
And that's a different thing altogether. But respecting a patient's situation and recognition that this is something they've avoided for long periods of time carries a certain risk. And the thing that I hear a lot in practice is patients going on, what, I've been sitting up like this for so long, it hasn't felt comfortable, but I thought it was the correct thing to do. And now this kind of slumpy posture feels completely relaxed. Why the hell have I been doing it? I
mm,
think it's really important that we validate their experience and their journey to that point. They would have seen lots of people where the messaging would have been unhelpful,
mm.
and they've been the recipient of that, and we need to respect that. And I think they have to be handled quite sensitively.
Yeah, yeah, absolutely. Yeah, people have their reasons for their beliefs. Even if it doesn't always make sense to us, it makes sense to them.
Yeah,
Um,
yeah,
you know, there's no, I've learned, I'm sure the same thing, like what is rational and irrational is very individual, and
yeah,
people form their beliefs and behaviors for all sorts of reasons.
yeah.
And there's always, whether how true the reason is or not, there's always a why behind it, so to speak.
Yeah, there is, and I think there's this fine line between validating a patient's experience but not validating their beliefs that you know to be unhelpful.
Mm,
And I think there's a very fine line between those two things.
mm,
Like patients that we see in practice, and you would have seen those, Ben, time and time again. They've had an incredible journey. They've
mm,
got really unhelpful beliefs that
yeah,
clearly represent barriers to living the best and fullest life
yeah,
and pursuing key things in their life. But that's been their exposure. And often it's healthcare practitioners that they've been on the receiving end. That's been their
mm,
experience. And so you have to kind of validate that experience,
yeah,
like understand it and recognize that they've been on a journey. But equally, we're in a position. We've talked about the timing of that. We've talked about the mechanism of how we do that. But we don't want to be validating unhelpful beliefs.
mm,
There's a timing issue, there's a context issue,
yeah,
there's a way of doing it. And we think the behavioral experiments, and certainly in my experience of 20 odd years working in around this space,
mm,
is that it gives you the greatest leverage to
mm,
shift beliefs and provide reassurance. Because as you
mm,
say, it's about going, look, you've experienced the change. What does that tell you?
yeah,
What did it feel like in your body, and
yeah.
what did it feel like to do it differently? And there's something very powerful about that.
And there's lots of open questions. It's essentially kind of get them to come up with the answer, right? And people often think about open questions at the beginning of taking to an assessment and taking a
Mm.
history, but they're also useful at these other points as well. It's not like you go from your open to your closed cone and it stays closed. It
Yeah,
can open up again.
Yeah, no, absolutely. And that again, what that speaks to is this kind of sense of formulaic approach rather than adapting your communication. But you know, if it doesn't mean that closed questions are a problem
Mm,
because, but it means that open questions, you don't want to dictate terms. You don't want to constrain people and constrain them in terms of their responses. So,
yeah,
as you say, what is it, what do you notice about the way you bend?
yeah,
It's not telling. Now, if the patient notices nothing, what do you notice about your breath?
mm,
So you start to nudge them towards the possibility of what we call candidate questions. So you start to give them options around some consideration of body part, but you start very open. What
yeah,
do you notice about your hands? What you're doing on your thigh? What do you notice about the tension in your back? What do you notice about those things? You start very open, but you
mm,
might need to focus that down a little bit. But you're absolutely right. It's the same as the conversation you have before and after
mm,
exposure. What was your experience? What did you notice happen?
yeah,
What did it feel like? Did you expect that? So these questions around getting the patient to think
mm,
and shift their thought towards behaviors. So you've got patients that have been consumed, that have been catastrophized, and that have been hypervigilant and overwhelmed by their pain and their experience of disability. And you're shifting the focus towards behaviors that underpin those things. Well, that's quite a shift.
yeah,
For the hypervigilant patient, that's a useful tool. Not only do they need to give consideration to unhelpful behaviors, because that's their way of successfully being exposed to the thing they've avoided, but it also puts a focus on something different.
mm,
And that's a really important thing. So our questioning around how we direct focus to those behaviors is really important, like
mm,
super important. And those questions that we've talked about, they shouldn't be rushed.
yeah.
There's time that you need to take around that whole process, and that needs to be done quite methodically.
I'm sure people are wondering because people have all had the experience.
Mm,
You've got someone, let's say, we'll use bending as the example,
mm,
and you're asking someone, what do you notice? Even if you get them to, I don't know, breathe and relax, and they're just saying it hurts, or you
yeah,
just you're getting the sense that this isn't,
yeah,
it's making the situation worse rather than better.
yeah.
Uh, do we aim for something else or
Yeah, so that's
flip
a
the
really good
script?
question. When you're dealing with patients with high levels of threat
Yeah,
around movement, with high levels of co-contraction, high levels of stress, huge levels of distress and worry, massively ramped up autonomic nervous system and arousal, and all of those features are clearly apparent in your observation. Flicking of the eyes, apical breath. These are patients that are really super worried. Then levels of exposure have to kind of map out with that. Because if you expose people too progressively,
yeah,
rather than calming and turning the volume down on their system, it doesn't go so well. And
no,
that's part of what we do with mentoring, how you make that decision, that clinical reasoning, how you deconstruct movement with less threat and build up to more threat, how you deal with calming the system before exposure is massively important.
mm,
But you're right, it runs the risk of ramping up. And of course, then you run the risk of losing the patient, and all the things that you hoped you'd gain from that context are lost potentially. So it's really important that you don't become too progressive with certain patients, but that's around your clinical reasoning.
yeah,
That's around recognizing, and those patients that you see sitting in front of you, holding themselves tense, holding themselves, propping themselves, huge amounts of pain behaviors, clearly massive autonomic sympathetic arousal.
yeah,
They're not the patients that you associate with quick early exposure.
mm,
Patients can surprise you, of course,
of course,
but
yeah,
there has to be a clinical reasoning underpinning to that level of exposure. And you sometimes have to row back a bit because you
yeah,
sometimes get it wrong.
yeah, of course. And you were saying about the sort of like the tensing, the shifting side to side. Were there any cues that were classically missed, be it pain or comms wise, by clinicians?
In the context of behavioral experiments.
Or reassurance in the paper as well.
I think if we look at concerns not being elicited, then we've kind of spoken about that.
Yeah.
And I think probably the issue around emotional concerns was probably the big one. And we've talked a little bit around the possibilities of why that was. And I think that one of the messages that I think is really important with this is being attuned to those emotional concerns
Mm.
is really, really important. And we saw the evidence of that in the post-training concerns paper. And so I think we're back to missing concerns, and we're back to probably saying the emotional space was the difficult territory, and that was the thing that changed. The looking at the post-training concerns data, particularly around the emotional concerns, these concerns around living with disability, living with the consequences of pain, not being able to pursue valid activities, living with pain, were the things they dealt with so much better.
Yeah.
Uh, and that's around, and what we saw, which was better in terms of communication practice, was the body orientation, was the use of the chart, was the way that was integrated, was the way that patients were given messaging that it was okay to continue to talk. There was no
Mm.
sense that the patient was going to be moved away from this topic.
Mm.
And you would have seen this from clinical practice, but this was an interactional way of looking at this empirically, was that the emotional talk is difficult territory. It looks peppered with pauses. It looks punctuated with difficulty.
Mm.
Patients don't say, yeah, I'm quite depressed. They don't say, yeah, I'm hugely anxious. They generally struggle, and we have to facilitate disclosure within that
Mm.
space, and empathy, and questioning, and building entitlement, and making relevant feelings talk is massively important. Because, and again, you would have seen this, and I get this all the time, is that people say, oh, it feels like a counseling session. Patients don't always orient or expect this type of conversation
Yeah.
to be part of physiotherapy patient interaction.
Yeah.
So there's an element of going, we need to make it something that is normalized. It's okay to talk about it. That's part of validating patients' experience. So these were therapists doing that. They were listening, they were watching. Their level of non-verbal interaction was mirroring the patient.
Yeah.
They was allowing small continuous in the talk. Yeah, okay. Was just allowing the patient. There was no sense that the patient wasn't going to be allowed to talk.
Mm.
There was no sense they were going to write away and recording the chart in these key sensitive moments. And so being attuned to that
Yeah.
in that way,
Yeah.
if we're preoccupied with our next question or our own agenda, we're not going to be attuned to those
No.
types. And
No.
so that's a very strong message. And I see that both in terms of my educational role, but also in terms of looking at the data that we've looked at.
Yeah. Interesting. Was there anything else that you found allowed the reassurance to go well that we've
No,
missed?
I think like listen, this was 20 cases, and
Mm.
so it definitely demands further study. It needs further looking at and drilling down. And this was pre-training, so these
Mm.
weren't trained therapists, and we could look at bigger populations and different patients with different levels of disability and various other things and different profiles. But we saw really they were the key things. It was just the foundational work
Mm.
around understanding concerns. It was giving information, reassuring information too early without having established those, being too premature in giving and telling. And then the bit that went well was going, look, I'm going to spend some time understanding whether these, for example, image findings are a worry to you. Is that something that you're concerned about? So the concerns questions,
Yeah.
are you bothered about that? Are you concerned about that? Is there something that's been worrying you?
Yeah.
Proximate to when the patient raises that as a concern is a conversation that needs to happen. And then reassurance then goes better.
Yeah.
And we only had the one extract around the behavioural experiment because this was pre-training in CFT. So these weren't therapists that had across the board pre-exposure to CFT. So this was just a group of purposeful sampled therapists doing what they did. Some of them had some exposure, but a lot of them hadn't. So we've got an interest now in drilling down on behavioural experiments, and we've got plans to look at that in a
Mm.
bigger way, in a focused way, with therapists that have been trained or in training towards competency, looking at therapists that are competent in CFT versus those that are not, and looking at that communication journey around the therapist with different levels of competency, and particularly around this whole space around the behavioural experiment. But that was just, that was just one case, and that was, pre-training.
It's interesting. Behavior experiments is I'm going to say a psychological thing that they've been doing for a little while. Is that right in psychology? Because our psychologists in our service do it as part of our programs, and it's um, been quite interesting seeing, as you say, the patients then have the experience and they reflect on it, and then okay, it's coming from them and it's their data.
100%, 100%. And when you look at our role in that,
Yeah.
the privilege of being a profession where we've got the license for touch and manual input, if you like, and
Mm.
how we use manual touch to facilitate behavioral change in a way that produces self-efficacy and agency in our patients and empowers them is like just a fantastic privilege,
Mm.
because the ability to lay your hands on a patient, for them to recognize where their breathing lies, for you to feel an area of sensitivity and to see that change,
Mm.
an area of hypertonicity, and to get them to appreciate, and how you use manual techniques to facilitate is such a judicious, important way of using that skill. And we have that license,
Mm.
and that's an important part of it. It's an important part of the behavioural experiment,
So
but not to breed passive dependency, to
yeah.
facilitate the patient's understanding
Mm.
that they are able to personally change the behaviour themselves,
Yeah.
so that they become their own coach.
Yeah. Yeah. So
Really.
before I get to your hardest conversation, one of the things I want to ask, you I was going to ask, was, and this came from a case study I actually had to write last year as part of my master's degree, and it was they asked us to write up this pick a case study which was particularly interesting, and it was someone I'd seen who fit the C everything we've been talking about tonight, the CFT, very actually almost a textbook example.
Mhm.
Uh, and the interesting thing was, as part of the thing I had to write was, why didn't this person get better? I've had CF tree training, not, I'll be honest, it was about 5 years ago now, but tried to implement everything we've been talking through. And I realized, and I reflected back on this essay, that, well, what I was talking through everything we'd said, she was getting messages from elsewhere. And it may have been, uh, there was other things as well. I think she experienced in the past, what was expected, etc. The fact that there had been medical input that had helped
Mhm.
in the past. And so I get, one thing I wanted to ask you was, we've seen all this, the Restore trial, we've seen all this good press, the Evolve stuff now out there. Who doesn't CFT work for?
I mean, it's interesting, but CFT is a broad framework.
Mm.
So it considers the bio as much as it considers the psychosocial. So it's a multidimensional framework
Mm.
that enables you to consider all patients with pain. And so, pretty consistent with what we see in with other approaches, we have to deal with ruling out serious pathology. We have
Yeah.
to deal with ruling out or in specific pathology. And so patients exist with nasty red flag disorders. We see patients with specific pathology with progressive neurological deficit. So I think people sort of wrongly kind of disconnect the bio from the
Mm.
psychosocial, and don't fully recognize the breadth of the framework that it
Mm.
absolutely considers that. Um, and so obviously that's what we need to triage those out. We need to see patients that are appropriate or indicated for treatment or not, and then signpost them towards management or investigations that are appropriate. I think that's one group that I
Yeah.
will talk about. The other group of patients that are tough are patients where social context is pretty unmodifiable. So when you go through an assessment with a patient, what you're trying to do is you're trying to identify the factors that are modifiable and unmodifiable. So what can we change here? Um, and with some of these difficult social contexts, they're difficult to shift. Going through bereavement, going through
Yeah.
financial worries. So some of the drivers for social stress and the context around pain flares are sometimes very difficult to modify.
Yeah.
And we need to recognize that and be honest with the patient. And this is me saying what's difficult, but there's also a conversation to be had around that.
Yeah. Yeah.
And these patients come with pain, with difficult social context, difficult social drivers, drivers of anxiety, drivers of stress, but they also often come with really unhelpful beliefs around their pain.
Yeah. Mm.
So at least we have an opportunity to make sense of their pain
Yeah.
and to give them a working model that's a reasonable model that understands their story, that recognizes and validates their experience. And yes, we can't change some of the stress drivers, but we can build tools around how they deal with stress in their life.
Mm.
And so there's ways around that, but some of those difficult social contexts are quite difficult to shift.
Yeah.
So I would say those are the things. There are some patients where we're always attempting to identify behaviors that are modifiable and to see whether pain is controllable.
Yeah.
And for some patients, I think quite small actually, but for some patients, pain is not modifiable. And the focus then becomes very much around active behavior and pursuing their goals and their valued activities,
Yeah.
and which it is anyway, but that becomes an absolute focus if pain is not a pursuable, controllable factor. But I have to say that in my experience, that's rarely the case.
Mm.
And I think that sometimes different approaches, psychologically informed approaches, that kind of focus on acceptance of pain before there's been a process around seeing whether pain is modifiable,
Mm.
um, doesn't always give the patient the opportunity for change. And I've seen quite a few cases where there's been a kind of acceptance values based model which for some patients is quite appropriate, but not where pain is being modifiable or demonstrated to be modifiable. What tells you about that? What tells you whether behaviors are controllable and pain associated with modifiable is back to your behavioral experiment.
Of course.
That's your test.
Yeah.
That's your test of whether you can change these things. So I've ended up talking about what you can change, what you can't
It's all
change.
right.
So that's my positive spin on it. But yeah, I think it's recognizing the framework and recognizing things that are modifiable and unmodifiable. And there's a big, broad framework that enables you to do just that. And that's part of the training approach that we go through.
Yeah, of course. There's been an interesting uh, amount of people recently where I thought what our service can suggest might help, but you need to, like a lot of them, move house first, or just get out of the environment you're in. I'm not saying that
Yeah,
for every patient, but there's just been a few where we thought, and there's until that context, as you rightly said, that
yeah,
changes,
yeah,
we can say all the right things.
yeah,
Like you said, timing earlier, it's not the right time,
yeah,
essentially.
yeah.
On that note, you were saying after that, it's just my interpretation. You're talking about what you think. The pain research in general, is
Mhm.
it becoming more hopeful? Do you think? I feel like looking at what people are putting out there, it seems to be a bit more of a positive spin in the past, maybe year or two, about recovery compared to what it used to be in the past.
I don't know, Ben. Really. I'm not sure. I always get slightly depressed with people's lack of optimism for change,
Mm.
and perhaps it is changing, and certainly within the cognitive functional model and demonstrating effectiveness and cost effectiveness in the way that Restore Trial has done,
Mm.
should really give people hope for change because these were patients with high levels of disability. And so I'm really hopeful, and training like we're involved with the Evolve project
Mm.
and creating access to training to upskill therapists is a way of providing hope because therapists don't have the tools to be able to deliver effective interventions often. And I know that was my own situation where I didn't really, 15, 20 years ago, I didn't have a framework in which to be able to operationalize this.
Mm.
So I'm really hopeful that now we're seeing some change, but there's still a big perspective out there that the longer you have pain, the less likely it is to be modifiable. And that doesn't reflect my practice. I don't see, yeah, listen, these behaviors can be very resistant. They can be
Mm.
tough to change.
Yeah.
And the longer they're established, unhelpful behaviors are stubborn, and we know that. But equally, pain that's been persistent for a long period of time can change.
Mm.
And I think we have to be hopeful for that,
Yeah.
absolutely hopeful for that. But it's not blind faith. We have a process within
Yeah.
cognitive functional therapy that enables us to have confidence. And if we're changing behaviors that link to changing pain behavior, that linked towards activities that align to patients' goals and valued activities,
Mm.
then we put people back on a path to reclaiming their life.
Yeah,
And
absolutely.
that's what we're all interested in.
Yeah, of
That's what
course.
we're all interested
Yeah. Ian, ask everyone this. Uh, what's been one of your hardest clinical conversations?
in. Yeah, I guess the difficulties in practice that I've had over the years, and I think has got better, and I
Mm.
think can still get better. Like we're all a work in progress, right? We're all getting better, and if we're reflective enough to look at practice, hopefully that just becomes a career journey, really. But I think the way I've deal with difficult and resistant beliefs, often of a biomedical nature, and the problems I've had in conversations around shifting patients kind of speaks to the change in my approach,
Mm.
and certainly in terms of the educational pathways that I'm involved with Evolve. When I see these students and the battle that I would have had with patients around, for good intention, trying to shift beliefs, giving information, and all this backfire, and not quite recognizing the need for a therapeutic relationship that probably foundationally wasn't strong enough,
Mm.
and dealing with these beliefs in a way that was creating backfire. And that created difficulties in the conversation. And you lose patience, you lose alignment, you lose therapeutic relationship. So I think they're really difficult conversations. And I'd like to think I handle those better now. And I think the way that I think I handle them better now reflects our conversation tonight,
Yeah.
really, is that I don't go too premature.
Mm.
I know a lot of information. I'm aware that there's some stuff that's being disclosed that's pretty unhelpful. You validate the experience and you pick your time. And I think that whole process of building your data and evidence to support both reassurance as an action, but also the making sense bit at the end has been a real transformation in my approach. Now, once you get to that part, you want to deal with unhelpful beliefs, you
Mm.
want to deal
Yeah.
with unhelpful emotions, you want to be able to deal with that. But by the time you've been through the interview, by the time you've been through a series of functionally relevant behavioral experiments, at that point it should really be a collaborative making sense process where the patient is invited to say, well, what have you learned from today? What did you make of today's session? And you have a conversation with patients where you invite them in to give their views and perspectives. So it's again not telling.
Mm.
It's around the patient and you drawing the dots together to make sense from all the multidimensional factors that relate to the patient's story,
Yeah.
using words that the patient references their problem, using metaphors that resonate with the patient. It's not just delivering pain science education.
Mm.
This is putting their story together in a way that makes sense to them.
Yeah.
And that's a really important part for me, because that's your opportunity to draw it up for the patient's involved. The reflective question goes on.
Mm.
That doesn't stop.
Yeah.
So your insights from what you think the patient understands are strong at this point because you're hearing back from them. And that really shouldn't be, you should kind of come to expect that because you've been on a journey of building understanding to that point.
Yeah.
Now, if you say to the patient, what do you make of that and what have you learned from today? And they're going, well, something really oddly biomedical at that point, then you know that you've got to go again,
Yeah.
missing from that. But it gives you a way of checking it out. But I think at that point, you're building that momentum to that point. But
Yeah.
I can't stress enough the need to elicit the perspective of the patient.
Yeah.
to
Absolutely.
build in the active participation of the patient, to
Mm.
use communication in a way that lets the voice of the patient lead and you guide. And those things are super important. Otherwise, it just becomes the expert giving information. And
Yeah.
we know that that has problems.
Right.
And I
Mm.
think that reassurance paper speaks to that, but I think it goes
Mm.
way beyond just reassurance as an action.
Yeah. Final question before we finish. Could this all be applicable? Obviously, your research was with back pain and CFT, but can we apply all of this, not even with physio, like I'm talking not even any pains, or just across other parts of medicine as well?
Yeah, I mean, if we talk about MSK and we talk about physiotherapy, so this is
Mm.
not the remit of the back at all. I mean, a lot of the research around CFT has been done around spinal pain. It's the leading cause of disability in the modern world. So,
Mm.
of course, it's a priority and a focus, and it has been. But there's work that's going on, that's been going on around different musculoskeletal conditions.
Mm.
The whole narrative and the story around arthritic and OA is another interesting area. But this, for me, is a way of thinking. It's a framework in which I approach all musculoskeletal pain. This isn't I don't put my CFT hat on because it's a back pain patient. This is
No.
just an approach.
Yeah.
This
Yeah.
is just an approach. And it serves me well in terms of, conditions beyond the spine. In terms of model of care, this is person-centered care. This is putting the patient at the heart of the interaction
Yeah.
and valuing the voice and creating space for the patient. So, it absolutely goes beyond our particular professional context. And I think in other areas, medicine particularly, they've been way in advance around work and research in this space. And I think that we're catching up, and that's why I've said it already a few times that we haven't had the empirical foundations
Mm.
on which to base some of the guidelines. We know the guidelines stand up, of course. I'm not arguing against them, but we need to look at what goes on in practice. And some of the work I've been involved with has attempted to do that. And I think that then becomes informative as training and what needs to happen.
Yeah.
And so there's still lots to do. There's still
Mm.
lots to do. But we feel very proud of the platform that we've got because there's something out there that therapists have as a structure to be able to embed this type of work, to have a framework in which to embed psychologically informed components,
Mm.
to have a framework in which they can develop communication skills through the lens of actual cases, through the lens of empirical data. And if they so choose, there's a pathway towards the goal of mentoring to change clinical behavior. And so
Mm.
that's all available depending on what your appetite is for this space, really.
And the Evolve Academy, available online now. It's been out for about almost 2 months now, isn't it?
Yeah, yeah,
People can go and access. I'll put the link in the description, but
absolutely.
it's been spread far and wide, hasn't it?
It
Um,
has, and we love feedback on it. Like,
okay.
this is this is an evolved platform, and it's going to be informed, and future iterations or additions are going to be informed by feedback. And so we're a very, very open group about that, and would love to know what people's thoughts and experiences of it.
Mm.
That's key for us. And so, yeah, if people are looking at it and have gone through tier one and have gone through knowledge, what's helpful, what's not helpful, what's been your experience of that? We don't think there's much out there at the moment, so we would love to know what your thoughts are on that.
And people can do that. Is there an email or is there some place on the site they can do that?
Yeah, so they can email and register interest and sign up for that.
No. People can, Ian, people can find you on LinkedIn
Yes, they can.
and X or Twitter.
Yeah.
Anywhere else?
Um, no, I think that's it. I think that's it. I'm around.
Is there anything we've missed that you wanted to say that we haven't covered?
No, I think we've covered heaps, and it's been really a great opportunity to kind of talk about the work.
Yeah.
And I haven't had an opportunity to do that, and I appreciate your interest in the work. And I haven't got all the answers, and don't claim to have.
Mm.
And I think that we as a profession are going in the right direction. And I'm involved in teaching, as I said, in the Evolve project, but also at undergraduate level. And I do see change, but we need to be clearly moving further down that direction. And I think that, we're in a tremendous profession that has unique aspects to it. And we need to value those and we need evidence around those particular things. And, I've made a very modest contribution to that. But yeah, it's been an interesting journey. and communication is a real fundamental competency that permeates all aspects of CFT. And as much as there's different competencies, that is the underpinning to everything we do, and not just CFT, as you know. Well, that's
Yeah.
been a big passion of yours, and so we just need to be upskilling people. And I think through the Evolve project, we've got this equitable access, so it provides education for all, and all proceeds go back into the project and the vision to provide further resources for people. So, yeah.